Trauma care is always evolving. Today, ATLS Edition 11 raises the bar with smarter, sharper, and more streamlined guidance. It challenges old habits, unlocks the new strategies, and puts life-saving precision at our fingertips. Let's explore what's new and what is improved, and also what will redefine the way we save life in trauma. The revised guidelines underscore the importance of the evidence-based practices in trauma care. Research-derived recommendations aim to optimize the clinical outcomes and reduce complications during the patient management in trauma. This manual consists of 3 main sections. Section 1 focuses on the evaluation, management, and resuscitation of injured patients, covering topics like initial assessments, airway management, hemorrhage control, and communication within the trauma teams. It includes updates on the thoracic trauma and geriatric considerations. Section 2 introduces new subjects such as trauma systems, triage, injury prevention, and trauma-informed care, while the third section discusses the specific injuries, including updates on the penetrating trauma and injuries on the combat zones. So overall, the manual emphasizes the importance of the advanced trauma life support principles and expanded content for the modern trauma care. Also, there will be discussions in the manual, and there is ATLS, which is the mobile ATLS, and My ATLS, which is the app, is coming back. It is coming back to the to be used again. And the most interesting thing is that the appendices are removed from the new book. So, in general, the book emphasizes on 3 main groups of talks or topics. The first group is trauma care organization, trauma society, and the second group is the ATLS core. They added the X in front of the ABCDE, and the third, which is the injury pattern, situations, and management. Looking at the content breakdown, you can see these are the 3 groups of topics in the book. 3 main groups. In the first group, which is trauma care organization and trauma and society, they added elements of a trauma system, injury and violence prevention, keeping the patient central and social determinant of health, and they added also goals of care principles in the acute trauma setting. While in the second group, which is the ATLS core, they added the X in front of the ABCDE. The X is the exaggerating in external bleed. So how to control it should be controlled before the ABCDE, and we are going to discuss about that one. And also the third group, which is injury pattern, situation, and management, they added penetrating trauma section or the chapter, and they discuss how to manage the penetrating trauma in details. Looking at the new concept of ATLS, you can see that it consists of X, A, B, C, D, E. So X is the external exaggerating hemorrhage control. It makes sense. I think it makes sense, because if the patient comes to ED and the patient had a trauma and there is a bleed, the bleed should stop before starting the ABCDE. So X before ABCDE makes a huge sense. There is a concept in ATLS, which is the weave concept. So weave concept is that providing all the elements of the ATLS, XABCDE, with high team functioning. And this high team functioning facilitates optimal patient care through prioritizing or by prioritizing the, first of all, safety. You have to have safety for the patient, for the staff, bidirectional communication, which is really important in the trauma, effective handovers. There are so many stuff added for the handover, so we are going to discuss them, we are going to talk about them. Also, in the weave concept, it consists also the respect for the cultural traditions, trauma-informed humanistic care, and patient-centered communication and care. So these are the things. This is what we call it weave concept. It means that the roles are woven through the entirety of the course. So it's like we are not going to teach only the XABCDE. We are going to teach communication, cultural respect, humanistic care. So all of these elements in the ATLS, these are what we call them the weave concept for the new ATLS. The section 1, which is the evaluation, management, and resuscitation of the injured patient, emphasizes a streamlined initial assessment by reducing the initial survey time to focus on the vital intervention for the life-threatening conditions. The aim is to enhance the patient prioritization and resource allocation during the rapid evaluation. The concepts for the initial assessment in the primary survey, there are 3 important concepts. Greatly enhance the ability to manage injured patients regardless the environment where the care is provided. Treat the greatest threat to life first. That's the most important thing. The lack of definitive diagnosis should not delay the application of the urgent treatment. And an initial detailed history is not essential to begin the evaluation and treatment of a patient with acute injuries. Looking at the primary survey modification, the latest edition removes the 10-second survey to emphasize the continuous assessment. A focus on simultaneous interventions and prioritization of life threats ensures a rapid identification and management of the critical condition. The XABCDE algorithm provides clinicians with the systematic approach to identifying, prioritizing, and treating life-threatening conditions. The introduction of the dynamic trauma evaluation allows for the real-time identification of patient needs through the integrated teamwork. Emphasis is placed on continuous evaluation and evolving management strategies tailored to each patient condition. The resuscitation team function and communication is a new chapter. Efficient communication and defined roles within the resuscitation team enhance patient outcomes. Standardized protocols promote teamwork, ensuring all of the members of the team understand their responsibilities and can effectively coordinate interventions during the critical condition. So it provides safety for both patients and team members. The structured pre-hospital ED handover format, which is MIST, has been changed to IMIST, ? And AMBO has been given as AMBO ? So IMIST, I stands for the identifies patient name and age, and the question mark is the period provided for questioning if there is any question by the clinician who is receiving the trauma patients. The AMBO ? As well, A for allergy, M for medications, B for background history, and O for other information. And also the question mark is for if there is any more question to be asked by the receiving team. The pre-arrival huddle is important as well to give rules to the personnel who are dealing with the patient who is coming. There is a 3 C's communication. 3 C's communication actually is important because you are, by using that one, you are going to cite names, there will be clarity of instructions and closed loop communication. That gives clarity for the instructions that you are going to give to every single member of the team who are dealing with the patients, with trauma patients. There is another acronym actually for a graded assertiveness for speaking up in time of a crisis. This is important. So we call it COS. COS is, C stands for the concerned. So we say, I'm concerned that we are missing tension pneumothorax or missing some internal bleed. U is, I'm uncomfortable that the patient has got, for example, still hypoxic with this treatment or still hypotensive. And S is safety issues. Is the patient safe to go for the CT scan or not while he is, for example, hypotensive? So COS is graded assertiveness, which has been added in the new edition. There is also a new acronym, which is the Take Stock. It is for the debrief. It's a debrief tool. T stands for Take an instruction sheet. A, ask, is everyone is okay? K, know if anyone needs a break. E, is there any equipment issue? And S, summarize the event. What happened? We've done this, 1, 2, 3, 4, 5. We received the patient, we've done this. And T is what are things that went well? And O, is there any opportunities to learn from what we had, what we did? And also, C is a cold debrief. Is it necessary or not? Do you want to do it now? Do you want to do it after in 2 days? Which we call it called debrief. And K stands for the know who is present in the team. So these are the things that we look at in the communication chapter for the 11th edition of the ATLS. The other modification in primary survey is the X, which is the control of the exaggerating hemorrhage. It's a new priority. Rapid hemorrhage control takes precedence over the airway in patients with a massive bleeding, redefining the classic ABCDE to XABCDE. Tourniquet and hemostatic agents undressing. There is emphasis on early use of the tourniquet and hemostatic dressing in hospital setting. And this emphasis on the application of those tourniquet for the extremity wounds with rapid bleeding from the large vessels or with multiple sites of bleed. And there is also a very nice drawing provided by the book to show us the common sites of bleed, the most common sites of the bleed in the trauma. In airway assessment and management with the restriction of cervical spine motion, there will be new scenarios, and there are no new skills added in the airway. It is a context-based approach. Context-based approach encourages individualized airway decisions. Not all the trauma cases require airway management. The oropharyngeal or airway, insert correct way up with the tongue depressor. So we are going to use tongue depressor in adults like we use it in pediatric cases. Intubation should be performed with the drugs by using the RSI. Keep in mind that hypotensive effects of RSI, they are emphasized. So if there is hypotension, start resuscitation. Also keep in mind that the first attempt at the intubation is your best attempt. If it didn't work, wait for the specialist to confirm the presence of the endotracheal tube. Should be done by measuring end-tidal CO2 over 7 breaths. Also, in this chapter video, laryngoscopy has been discussed. Patients benefit from the immediate intubation and drug-assisted intubation in patients with the circulatory compromise. You must consider hemodynamics first. The modified RSI is the preferred intubation technique with pre-oxygenation and apneic oxygenation via the nasal cannula if it is not contraindicated. Also, avoidance of over-sedation and hypotension through careful drug selection and dose adjustments, they are advised by using the drug-facilitated intubation. Etomidate and ketamine are preferred for their cardiovascular stability. Use of vasopressors preemptively if patient is hypotensive. In pediatrics, the commonest avoidable cause of death is failure of oxygenation and ventilation, which is completely different from adults, because the cause here in adults is the bleeding and hypovolemia. So it's important to avoid that cause of death in peds by proper oxygenation and ventilation. Sometimes when you start with the drug-assisted or drug-facilitated intubation, some pediatric patients, they develop a bradycardia, so have the atropine available with the RSI. If oxygenation and ventilation are adequate, the manual advises to delay the definitive intubation until the conditions are optimal, like, for example, personnel, equipment, hemodynamic stabilization. These are important because these are the common causes for the difficult airway. So either environment, injury, physiology, or anatomy. So try to make sure that optimal condition prior to intubation should be provided in order to achieve a secured airway. For the breathing and ventilation assessment and management part, there are no new skills. The percussion is not a part of exam. So look, listen, and feel. So there's no percussion anymore. Smaller gauge needles for needle thoracostomy were highlighted for needle decompression in thinner patients or children. There was an emphasis on the depth and catheter length, especially in obese patients. chest drain size, they have mentioned the size 14 for Seldinger and 24 for the surgical one to be the management for both hemothorax or pneumothorax. There is no need to go for higher size. Massive hemothorax is not defined in the book, but in the scenario, if the patient is hemodynamically compromised, this needs to be worked out. With regards to needle decompression, needle decompression has been moved laterally or anteriorly. So previously, we used to do needle compression on the fifth intercostal space anterior to the mid-axillary line. But now, there are options, either the second intercostal space adjacent to the mid-clavicular line, or to the fifth intercostal space between the anterior and middle axillary lines. With regards to the fifth intercostal space, how to find it on the surface anatomy, we used to do it from the sternal angle, which corresponds to the second intercostal space, and then go down to the fifth intercostal space and go laterally. But now, the fifth intercostal space you can find it with the inferior mammary fold or inframammary fold, which corresponds to the fifth intercostal space. So that will be mentioned in the teaching as well of the ATLS. Finger thoracostomy for emergent decompression has been mentioned, and it is more suitable for the pre-hospital settings. With regards to the point of care ultrasound, it has been recommended in the chapter for rapid diagnosis of pneumothorax or hemothorax. They mentioned also if the patient has moderate to severe thoracic injuries, this is an indication for the transfer to trauma center. In circulation assessment and volume resuscitation, as we know now, X is major, which reinforces that massive hemorrhage can precede all the other steps. So X and stop the bleed discussed in C. Hemorrhage control remains the highest priority in trauma care. Techniques like direct pressure tourniquet application and hemostatic dressings have been updated to emphasize an early intervention and effective application to prevent exsanguination. Tranexamic acid is recommended if less than 3 hours since injury. So either you give 1 gram followed by another gram, or you give 2 grams instantly. Minimize crystalloids. The advocates of limiting crystalloids is to prevent dilutional coagulopathy and acidosis. Early whole blood transfusion may be better than the fractionated components of 1:1:1, and this is based on the fact that whole blood is considered safe, efficient, and often more effective early in massive hemorrhage when available, because it better replaces the lost blood in its natural balanced form. However, 1:1:1 component therapy remains the standard where the whole blood is unavailable. Okay. Hemorrhagic shock classes are no longer used. Instead, the book provides with the non-hemorrhagic shock subdivisions into obstructive, distributive, and cardiogenic. So these are the new subdivisions of the non-hemorrhagic shock. Also, there is introduction of the shock index, which is equal to heart rate divided by the systolic blood pressure, and it should be less than 0.7. If it is more than 1, this means that there is an increased mortality in the context of the trauma. Autotransfusion and cell saver are not discussed in this chapter. Also, there is a detailed anti-clotting medications mentioned in a very nice table. This table shows the changes in clinical parameters as related to hemorrhage severity, response to blood loss, which varies based on the patient factors and source control. So response to resuscitation is dependent on the presence of the continued blood loss, not on the specific volume of blood loss. And this one has been mentioned in the chapter. Also, there is a nice table shows the factors associated with variable response to resuscitation in pregnant, older adults, children, and athletics. In disability and neurological assessment, there are no new skills. In GCS assessment, M6 is a two-part command response by the patient, and V5 means the patient is alert to time, place, and person. There is a new terminology of neuroworsening, which has been mentioned in the new ATLS edition 11. Neuroworsening is rapid deterioration of neurological status that warrants emergent evaluation. The clinical signs are spontaneous decrease in the GCS motor score, new decrease in pupillary reactivity, new pupillary asymmetry, bilateral dilated pupils, new focal motor deficit, and Cushing's triad, which is widened pulse pressure, bradycardia, and irregular respiration. So this is what we call it the neuroworsening. The spinal movement restriction is a new terminology that replaces the spinal immobilization. Also, there is a use of reverse Trendelenburg in traumatic brain injury. The older approach, which is the flat supine, has been modified. Supine is still used for spinal precautions, but reverse Trendelenburg is recommended when head injury or increased intracranial pressure is suspected, as long as the spinal alignment is maintained. Always align the spine, use the log roll and the neutral position or neutral support before tilting the table. There is a table for updated targets in a traumatic brain injury, and you can see this table. They added a mean arterial pressure of more than 80 millimeter mercury. And also there are some changes in the parameters here. Pulse oximetry from 94% and above, which was more than 95. Glucose 100 to 180, it was from 80 to 180, and PaO2 was more than 100, and now it is from 80 to 100. There is another table about the blood pressure goals for traumatic brain injury and spinal cord injury. If the patient is 15 years old and older, in traumatic brain injury, systolic blood pressure to be kept from 100 and above, and in spinal cord injury, the mean arterial pressure should be more than 90 millimeter mercury. If the patient is less than 15 years old, systolic blood pressure to be more than the 5th percentile for the age. In spinal cord injury, the American Spinal Injury Association impairment scale now is the standard for the spinal cord injury classification, allowing detailed documentation and prognostication. Also, early recognition of the spinal cord injury syndromes provided by detailed syndromes like Brown-Sequard syndrome, central cord syndrome, anterior cord syndrome, described for earlier diagnosis. In spinal movement restriction, which is SMR, there are no new skills. The triple immobilization is not mentioned in the manual. In penetrating trauma, routine SMR is not indicated because if you spend time putting the SMR properly, in patients with the penetrating trauma, mortality will go high. However, the SMR and the cervical collar may be indicated if clinical exam indicates potential spinal trauma. Taken in consideration, if you have a patient combative or extreme of age, you have to consider these two conditions. In September 2025, the ATLS UK steering group confirmed that semi-rigid collars remain essential for patients' extrication and should be used with manual inline stabilization when removing blocks and straps. Once patients are secured on a scope, vacuum mattress, or trolley, the collar can be removed as it offers a little additional benefit. Cervical movements restrictions should only be lifted after formal clearance. In exposure and environmental threats to primary survey, which is a new chapter name, hypothermia and hyperthermia updated to include better assessment. The E component of the primary survey has two major goals: full body exposure to ensure the identification of external signs of injury, and identification and immediate treatment of the life-threatening environmental injuries. For major burns, initiate fluid resuscitation by using lactated ringer solution based on age cutoff before calculating the total body surface area. So in age of 13 years old, for example, use 500 mils per hour. In age between 6 to 12 years old, use 250 mils per hour. And in age 5 years old and under, give 125 mils per hour. The fluid volume in adults equals to 2 mils multiplied by body weight multiplied by the total body surface area in 16 hours. And the volume is increased in electrical burns. For frostbites, rewarm by immersion and rewarm the affected area by immersion and evaluate for the possibility of thromboembolic therapy. In secondary survey, which starts when the primary survey is completed in a hemodynamically stable patient quickly, no new skills added, log roll to be practiced, ample is needed, reassess vital signs frequently. Also, there is a mentioning of a term called fall LD50 11 to 18 meters, means the lethal dose to 50% of population to fall. What are the possible injuries? This has been mentioned in one of the tables. Be aware of the difference in terms of the ground floor and first floor between UK and US. In US, they call the ground floor as the first floor. So be aware of this difference when you face some of the questions. In hemodynamically stable patient, consider tourniquet conversion when vital signs should be normal, patient is not in shock, tourniquet was on for less than 6 hours, monitor for the reperfusion injury if the tourniquet was on for more than 2 hours, remove packing from the wound, loosen but do not remove the tourniquet. This is really important, you have to keep in mind. Always ensure that you have a new tourniquet available if the patient starts to bleed. Comprehensive examination is needed in the secondary survey and medications to be given like tetanus vaccine, antibiotics and pain management. Reduce the risk of delayed or missed injury evaluation by comprehensive examination as injuries evolve over time. Consider mechanism of injury in addition to physiological presentation to help to identify the evaluation need for every single patient. In transfer to definitive care, identify early which trauma patients require care beyond your facility and initiate transfer without any unnecessary delay. Stabilize life-threatening issues but avoid time wasting diagnostics that won't change the management. Ensure clear doctor-to-doctor communication, complete documentation, and proper preparation before departure. I'm just sharing this table with the new SBAR. The SBAR, the S, which is the situation that contains the XABCDE, which is according to the new updates. So this is the new SBAR acronym for the transfer or for referring the patient. Choose the safest transport mode and maintain continuous monitoring and critical care during transfer. Section 2 talks about trauma systems and patient-centered care. This is new in the 11th edition. Trauma systems are structured frameworks that coordinate emergency medical services, hospitals, and rehabilitation services to ensure timely and effective care for injured patients. These systems are designed to eliminate delays and improve outcomes by facilitating rapid assessment and treatment across various care settings. Trauma systems aim to reduce mortality and morbidity while improving quality of life after trauma. They represent a coordinated effort in specific geographic areas, providing comprehensive care for all injured patients integrated with local public health systems. Key elements of trauma systems include injury surveillance, prevention, emergency medical services, pre-hospital care, acute hospital care, rehabilitation, performance improvement, education, and research activities. The quality improvement programs are essential, and they have been shown to enhance the care processes, reduce mortality, and lower costs. The implementation of trauma system principles varies globally, often limited by the healthcare resources, infrastructure, and the need for supportive governance laws and regulations. While the patient care or patient-centered care, it emphasizes the importance of involving patients in their own care decisions and addressing their individual needs, preferences, and values. This approach enhances the emotional and psychological aspects of recovery, leading to better overall satisfaction and engagement in healing process. In triage and disaster management, mass casualty incidents require a change in the concept from individual patient care to a population-based care. The ATLS principles are the same, but they are applied differently during the mass casualty incidents. The phases of disaster management include ready phase, response phase, and recovery phase are applied in mass casualty incidents. The incident command system is standardized. All risk incident management framework, which allows its users to respond effectively to a single or multiple incidents without being hindered by low boundaries. Maintaining clinician safety is important, and also maximize the available resources to save as much or as many as possible. Plan for austere conditions and possibility of a mass event incident when it happens. Injury prevention This is a new chapter based on the concept of understanding the risk factors that make injuries more likely within certain mechanisms. Makes it easier to apply prevention approaches and concepts. So this chapter was added to the new edition because trauma care is no longer just about treating injuries. It also emphasizes preventing them before they occur. If we look at the weave concept of ATLS, you can see that prevention is a core theme that ATLS now embeds throughout this program. So knowing mechanisms of injuries and risk factors lead to know how to prevent them from occurring. Just to keep in your mind that, or always remember that trauma or injury is a no accident. Most trauma and injuries are preventable. The frontline trauma clinicians are in a unique position to contribute to injury prevention efforts locally, regionally, and nationally. Learn about the injury context for patients once it is safe and feasible to do so. Collecting injury data can be helpful to inform the local and national prevention efforts. If your facility, for example, encounters high volume of certain type of injury mechanisms or treats patient populations that is particularly impacted by injury, consider targeted injury prevention interventions. When screening for risk factors, clinicians should ensure that options for the referral are available to the patient. The classic public health prevention model is called 3E's approach, has been added in the 11th edition. It contains engineering, environment enforcement, and education. With regards to education, talks about the driver education courses, education about vehicle maintenance, community education like consequences of driving under the influence, speeding, texting, not using restraint, education of special populations like teenagers or old drivers, post-crash counseling. With regards to engineering and environment, vehicle design, handling, airbags, road design, analysis of unanticipated consequences, like for example fire from gasoline tank or electric vehicle battery, presence of organized emergency responses and appropriate care facilities. With regards to enforcement, talked about advocacy for legislation regarding substance use, speeding, restraint use, and texting while driving. Also analysis of effective enforcement of speed limits, vehicle functioning, and community or social advocacy for pre-hospital acute trauma and rehabilitation care. So these are all provided in the injury prevention and the 3E approach in the book. There is a new chapter called Trauma-Informed Care and Social Determinants of Health. There is a case scenario in the book, so some discussion about it. The social determinants of health are conditions in which people are born, grown, work, live, and age, and can be grouped into 5 domains: the built environment, economic stability, education, access and quality, healthcare, access and quality, and social and community context. The social determinants of health directly impact health outcomes for trauma patients. Traumatic stress affects people differently. Patients and healthcare workers are at risk of developing psychological injury from trauma care experience. A trauma-informed healthcare system works to mitigate injury for all patients involved. The trauma-informed care involves the 4 Rs: realizing the widespread of impact of trauma, recognizing the signs and symptoms of trauma, creating a system that responds to trauma, and avoiding re-traumatization. Trauma-informed communication demonstrates compassion and empathy for patients, families, and colleagues, while avoiding preconceived judgments and sarcastic comments. There is another new chapter that talks about communicating serious news in the acute trauma setting. Patient updates and goal-setting discussions are crucial for high-quality trauma care. These conversations should take place promptly after initial assessment and stabilization, or upon significant changes in patient status. Preparation for sharing serious news is essential to prevent misunderstanding and build trust. Clinicians should use headline statement with a warning to set the appropriate tone to difficult discussions. The ABCDEs of communication serve as a guide for clinicians during the family meetings, fostering meaningful and empathic interactions. Always remember, documentation of family communication, it's important and should include discussion details, family awareness, participant lists, primary surrogate contact information, stated goals, and any care limitations. And also remember that this documentation must accompany the patient if they are in a transition or if they are transferred to another place of care. Section 3 talks about specific injuries and injury patterns with special considerations. With regards to thoracic, abdominal, pelvic, and genitourinary trauma, management of abdominal and pelvic trauma requires swift evaluation to identify internal injuries. Key interventions include stabilization of hemodynamics, imaging studies for the diagnosis, and potential surgery to address the damage or hemorrhage. In other chapter that talks about the penetrating trauma, proper management of penetrating trauma requires a thorough assessment and prioritization of the life-threatening injuries. Techniques like wound exploration, control of hemorrhage, and stabilization of the fractured bones are essential to prevent secondary complications. Also, there is a mentioning of the anatomic zones of the anterior neck. So you can see that zone 1, zone 2, and zone 3. The value for this one is that it provides a common anatomic language, helps anticipate what structures may be damaged or injured, and is useful in initial triage and communication. Historically, guided when to explore surgically or to do imaging. That was in the past. Limitations for this one is that external wound location does not reliably predict the internal injuries. Rigid zone-based protocols can lead to unnecessary surgeries or conversely missed injuries if relying on the zone only. So modern practice, as reflected in ATLS style thinking, use zones as descriptive framework but combine with clinical science, hemodynamic status, and imaging to guide the management. Except that zone is the only piece of the puzzle. Also, there is a mentioning of the cardiac box. This is the cardiac box and the extended cardiac box. Cardiac box defines the anatomical region where penetrating trauma has much higher likelihood of injuring the heart, pericardium, or major intrathoracic blood vessels. By explicitly defining this region in the ATLS 11th edition, the guideline reinforces that the idea that even small or apparently benign wounds in this area warrant serious evaluation. The ATLS edition expands beyond the traditional borders of the cardiac box to include additional zones where injuries trajectories may still reach to the mediastinum, which we will call the extended cardiac box. This helps to prevent under triage by acknowledging that cardiac injuries can occur from the wound paths outside the classic box, depending on the angulation and the depth. Knowing a wound is within the cardiac or extended box triggers a mandatory EFAST scan or focused cardiac ultrasound, early CT scan of the chest with the contrast if stable, emergent pericardiocentesis or thoracotomy if unstable. Well, talking about thoracotomy is more reliable here, and lower threshold for cardiothoracic consultation. This aligns with the ATLS shift towards early use of ultrasound and more nuanced imaging pathways. There is a new score in the new ATLS book called Assessment of Blood Consumption Score, which is ABC score. This is derived from easily attained measures including systolic blood pressure, heart rate, positive FAST scan in the presence of penetrating torso injury. A score of 2 or more increases the chance of needing massive transfusion. There's a new chapter called the ocular trauma in the new book. Ocular injuries have the potential to blind the patient. Vision-threatening injuries require treatment promptly after the onset. So perform the ocular examination during the secondary survey after stabilizing the life-threatening injuries and limb-threatening injuries. So always remember life, limb, and eyesight. Alterations in the eye3 vital signs, vision, pressure, and pupils can identify subtle ocular injuries that may threaten the loss of sight if not treated immediately. In the presence of chemical injuries, always irrigate, and irrigate. Prompt canthotomy and cantholysis can save the vision in cases of ocular compartment syndrome. Always protect the potential ruptured globe with the shield and prevent increased ocular pressure. When in doubt, at any time in the presence of trauma to the eye, consult the ophthalmologist immediately. Injury in combat zones and sterile environments is a new chapter. The principles of ATLS provide a framework for evaluating and treating the life-threatening injuries in all situations and environments. However, these principles must be adapted in the situation based on available resources. Early hemorrhage control with tourniquets is critical. However, tourniquets should be assessed or reassessed for replacement or conversion at the earliest opportunity. In military setting, the ATLS has a specific survey called ATLS OE survey. So the ATLS OE survey, it means ATLS Operational Environment Survey. This provides an expanded construct for assessment and resuscitation of the trauma patient in military setting. This survey incorporates tourniquets use into the primary survey and includes the zero and quaternary survey. If you look at the diagram, you can see the primary survey. We know the primary survey, secondary survey, and there's tertiary survey. So the tertiary survey talks about reviewing all the images, focus on musculoskeletal injury, evaluate the adequate resuscitation. And also, the quaternary survey talks about stability for transfer, transport needs, receiving facility capabilities, critical care needs. There's a zero survey in the ATLS OE. It talks about tactical situation, personnel, logistics, holding capacity, and security. So this is the ATLS Operational Environments Survey, which is used in ATLS in military settings. The STAR and operational environments require increased situational awareness and detailed pre-arrival and pre-transfer assessments due to resource constraints. The acronym THREAT is used to guide response to mass casualty incidents or active shooter hostile environments where there may be ongoing danger besides the usual trauma hazards. By using THREAT, teams can ensure scene safety first, followed by hemorrhage control, and then rapid extrication, which might save more lives than the conventional slower trauma-based style primary survey. Also, it has been mentioned in the new book that the Stop the Bleed campaign provides the hemorrhage control training for the public and empowers immediate bystanders to act. The American civilian program aimed to teach non-medical people how to stop the life-threatening hemorrhage. It has been decided that in UK, the instructors, ATLS instructors, are automatically Stop the Bleeding instructors. With regards to skill summary, the new manual doesn't have skill summary appendix. The only skill mentioned in the book is the surgical airway. There is a summary of skills provided in my ATLS app. So, in summary, ATLS has evolved from a simple instructor-led survival course into a global evidence-driven, team-centered, competency-based trauma system focused on physiology, imaging, and modern resuscitation principles. Trauma doesn't wait, and neither does progress. ATLS 11th edition arrives with bold updates that reshape how we think, act, and save lives. It cuts through the noise with clearer priorities, smarter tools, and game-changing insights. Get ready to dive into this edition that's defining the future of trauma care. All the best.